Vestibular disorders can lead to significant functional limitations and deficits in the performance of daily activities. This video will review the vestibular disorders for the NBCOT exam, including OT evaluation and intervention for people with vestibular disorders. I'm Jeff, the OT dude, and let's get functional. I'll start with the symptoms commonly associated with vestibular disorders. The most common symptoms or complaints include vertigo and dizziness. One important thing to remember is that symptoms such as vertigo or dizziness are not diseases themselves, but symptoms of various diseases or other causes. For example, a side effect of many medications can also be dizziness. Vertigo is defined as the feeling like one is spinning around in self-motion when there is no motion occurring, or the sensation of self-motion during normal head movement. Vertigo is further classified as spontaneous and triggered. Spontaneous vertigo is vertigo that occurs without an obvious trigger. Triggered vertigo, as you can guess, is vertigo that occurs due to an obvious or known trigger. There are more specific types of triggered vertigo. These terms are kind of descriptive of the type of triggers, so I won't go deep into these as this is beyond the scope of what you will probably need to know for the NBCOT exam, but just for your information, more specific types of triggered vertigo include positional vertigo, head motion vertigo, visually induced vertigo, sound-induced vertigo, Valsalva-induced vertigo, and orthostatic vertigo. Last, there's also other triggered vertigos for those that do not belong in those kind of classifications. With vertigo, even sudden simple movements or changes in one's posture can trigger these sensations. It can have a significant impact on one's daily functioning, from functional mobility to work to leisure activities. And because of these symptoms of vertigo, they can also have a psychological impact on the individual, such as anxiety and panic attacks. Dizziness. You are probably familiar with this symptom as you likely have experienced this before. The definition for dizziness is the sensation of disturbed or impaired spatial orientation without a false or distorted sense of motion. Dizziness can also be further classified into two types: spontaneous dizziness and triggered dizziness, just like spontaneous vertigo and triggered vertigo. And actually, they have the same adjectives to describe dizziness as vertigo, just like how I mentioned earlier. So triggered dizziness types include positional dizziness, head motion dizziness, visually induced dizziness, sound-induced dizziness, Valsalva-induced dizziness, orthostatic dizziness, and other types of triggered dizziness. I wouldn't worry about memorizing these as much but being able to guess what the terms mean if you're asked on the NBCOT exam, as it's a good idea based on your existing knowledge of terms such as orthostatic, Valsalva. You can kind of deduce what type of definition they're talking about for the question. And as the NBCOT exam may sometimes like to ask questions or use terms that seem to come from left field that you may have not learned before, I will go over some other terminology associated with vestibular disorders to help you over-prepare for this. These first set of terms fall under vestibulovisual symptoms, so having to do with vision. They are oscillopsia, visual lag, visual tilt, and movement-induced blur. Oscillopsia is the false sensation that the visual environment is oscillating. In Latin and Greek, oscillopsia means swinging and vision, so this might help you to remember it. Oscillopsia is often described as the experience of bouncing or bobbing of the visual world. Visual lag is the false sensation that the visual environment follows behind a head movement with a delay or makes a brief drift after the head movement is completed. Visual lag may occur along with vertigo and or dizziness as well. Visual tilt is the false perception of the visual environment as oriented off the true vertical axes. This is sometimes referred to as the room tilt illusion or room inverted illusion. The last set of terms have to do with posture and are called postural symptoms. Postural symptoms has its own definition. It's defined as feeling postural stability, such as when one is seated, standing, or walking, related to how one's body changes with respect to gravity. More specific types of postural symptoms include unsteadiness, directional pulsion, and balance-related falls. Unsteadiness is defined as the feeling of being unstable while seated, standing, or walking without a particular directional preference. Directional pulsion is defined as the feeling of being unstable with a tendency to veer or fall in a particular direction while seated, standing, or walking. Thinking pulsion, like pull, can help you remember this. So now that you are familiar with some of the terminology, let's take a look at specific conditions. Here is a figure that shows the frequency of how various vestibular syndromes in one study of 34,000 patients in an outpatient clinic presented in terms of their prevalence. Functional dizziness is the most common of this sample, followed by BPPV, or benign paroxysmal positional vertigo. Third is central vestibular vertigo / dizziness. Fourth is vestibular migraines. And fourth is Meniere's disease. While it is not the primary role of the occupational therapist to diagnose people, I will review some of this information. I actually learned some of these tests at work from a PT student doing an in-service for vestibular disorders. And these may come in handy if you are trying to, say, rule out certain conditions, such as BPPV. This information can help you, then allow you to begin some basic treatment to alleviate symptoms, such as in acute care, or to provide a referral, if necessary, based on your findings. Assessment typically begins with taking a history and asking questions about what the symptoms are, when they began, and how long they may persist for. Other questions you can ask are what causes this, like a change in body position? And because we are OTs, is it caused by a specific activity that triggers it? Does it cause other symptoms along with it? You may sometimes hear the term attacks, as symptoms may have an acute onset. In terms of duration, vestibular symptoms vary in how long they may persist. Vestibular disorders have common symptoms, but there may be other symptoms called accompanying symptoms. Some accompanying symptoms that often go with vertigo and dizziness include tinnitus, ear pressure, diplopia, ataxia, dysarthria, hemiparesis, headaches, migraines, photophobia, phonophobia, and auras, which may occur in any combination of body positions or activities. Now, let's talk about some general screens that may indicate some form of vestibular disorder if suspected. You won't need to do this routinely in every evaluation like in other sensory testing, but it may be performed if the diagnosis may cause it. There is a history or a chief complaint of the earlier mentioned symptoms, things like that. You are probably familiar with nystagmus, or the bouncing of the eyes when asked to perform intentional eye movements and the eyes kind of don't listen. Nystagmus may be a sign of a vestibular disorder, but it is not a definitive test, as nystagmus can even be caused by other things such as excessive alcohol consumption or some drugs. A second clue is the vestibulo-ocular reflex, or VOR. The examiner asks the patient to focus on a point and quickly rotates the head of the patient in the horizontal or vertical plane back and forth. The eyes should stay fixated and stabilized normally due to the activation of a functional vestibular system. VOR allows us to engage in normal activities and movements such as walking or otherwise. Our eyes would be bouncing back and forth, making it very disorienting and dizzying as well visually. You may remember the vestibulocochlear cranial nerve. As this system is related to each other, a vestibular disorder may be accompanied by a hearing impairment as well. So be sure to check out my hearing loss NBCOT exam prep video if you haven't already to review more about hearing loss. Other screens include simple activities such as standing on one foot with eyes closed and seeing what the patient does and what happens. This is also called the Romberg test, which measures one's sense of balance. To remember this, think of the shape rhombus, which kind of looks like someone is standing on one foot if you rotate the shape so that it's standing on one of the corners on the bottom. Let's go into some of the disorders now. As we saw in the figure earlier, functional dizziness was the most common, but interestingly, it is a relatively new diagnosis or term that was first described in 2017. Functional dizziness actually describes several subtypes, but some symptoms include postural dizziness and unsteadiness. The dizziness and unsteadiness may persist for months and symptoms may last for hours per day. Symptoms may come on spontaneously and cause functional impairment. The diagnosis may be confirmed if symptoms cannot be better explained by other diagnoses, and is idiopathic. In terms of treatment, vestibular rehab therapy, or VRT, may help with these symptoms. VRT is a form of therapy that helps to alleviate symptoms associated with vestibular disorders. It involves an exercise program comprised of habituation exercises, eye gaze stabilization exercises, and balance training. Habituation, similar to behavioral theory, means exposing someone to specific movements that may cause dizziness over and over, and in time, the symptoms should subside. Also, cognitive behavioral therapy, CBT, and desensitization may be helpful with functional dizziness as it can be accompanied by anxiety and panic attacks. The second most common disorder was benign paroxysmal positional vertigo, BPPV. It's due to a problem with the inner ear and the most common cause of vertigo. The hallmark of BPPV is vertigo associated with changes in head position. The vertigo in BPPV is due to the small pieces of calcium that kind of come loose from their normal location and are floating around in the small inner ear canals. So the treatment of BPPV actually works to bring these calcium crystals out of these locations. With BPPV, there are two terms to remember for the test and the treatment, which is also called the maneuver. These are called the Dix-Hallpike test and the Epley maneuver. The Dix-Hallpike test can help to confirm BPPV. To perform it with the patient, while sitting up, the patient's head is turned about 45 degrees to one side. Next, the patient is quickly laid down backward with the head just over the edge of the examining table. This move can often bring on vertigo, and the examiner can observe to see if the patient's eyes show nystagmus. A positive response may confirm the diagnosis of BPPV for a doctor anyways. Once suspected of BPPV, patients can have a provider or therapist perform the Epley maneuver to help alleviate symptoms and for treatment. In fact, the most common variant of BPPV can be treated with the Epley maneuver, and no other needed surgery, medications, or interventions with a 95% success rate. The Epley maneuver involves the provider first turning the head towards the side that causes the vertigo because it's in one side of the ear, Then the patient is quickly laid down onto their back with their head in the same position, but just off the edge of the table. Their head is then slowly turned to the opposite side. Next, their body is turned so that it is in line with the head, and the provider will sit the patient upright. This may be repeated several times as needed or according to protocol. You should know that the contraindication to Epley maneuvers is carotid stenosis, unstable heart disease, and severe neck disease, right? Makes sense. You don't want to crank on the neck if there's neck conditions. One trick to remember BPPV relative to other vestibular conditions is think of the word benign, which means not harmful by definition. And BPPV can often be treated with the Epley maneuver with quick repositions for the patient for their vertigo. The last most common disorder vestibularly is Meniere's disease. It is also an inner ear disorder that causes spontaneous vertigo attacks, but is also accompanied by hearing loss and possibly even tinnitus. Symptoms typically last about 20 minutes to several hours, but usually no more than 24 hours. It often affects only one ear and is referred to as Meniere's disease when it is idiopathic and there is no specific identifiable cause. This is often because the cause of Meniere's disease is unknown. It is likely due to a combination of factors from improper fluid drainage to an immune response to genetics. In terms of prognosis, it is a chronic condition that can have a long-term impact on one's life. Treatment includes medications for symptoms, injections, and VRT, which was the therapy that used the habituation, eye gaze exercises, and balance training. Surgery may also be an option for Meniere's disease. And with these vestibular disorders, you may be wondering, how can we measure using outcome measures, such as with assessments? One outcome measure worth noting is the Vestibular Disorders Activities of Daily Living Scale. That's a long one. That describes functional limitations in patients with vestibular disorders by Cohen. Here's what the scale looks like, just as an example. And other scales would likely have relevant titles in their names for the measure, such as dizziness, vestibular, vertigo, steadiness, postural, and so on, and will likely be a good outcome measure to choose as well, such as the CST portion of the NBCOT exam. Now let's talk about OT interventions. By the way, are you enrolled in the OTDUDE NBCOT exam prep course? It's free to register and you get instant access to these videos, quizzes, and study guides and more in a single online course. The link is in the description. In general, here are some tips that you can provide patients who are having symptoms of vertigo and dizziness. Lifestyle changes may help, such as dietary changes like limiting salt, caffeine, alcohol, and tobacco, and other good, healthy wellness habits like rest and sleep. MSG, aged cheeses, red wine, and even chocolate has been reported to be a trigger. Other lifestyle choices may even have an effect on symptoms, so people should be empowered to gain insight into their own condition, especially if it is to be chronic, right? Each individual is different though, and say certain foods may be triggers for some, but not for others. When people do have symptoms, they can sit or lie down and avoid sudden movements. They should avoid bright lights, but also should avoid screens, and trying to focus on an object that is not moving may help. People can also get up slowly in the morning to allow time for their sensory systems to adjust to postural changes. After an attack, one should take their time when resuming activities and pace themselves. So pacing strategies, especially when driving, operating machinery, power tools, and other risky activities. They can plan their day and start with short and simple activities that allow for breaks and don't need to be completed like all at once. Lifestyle changes were mentioned to be helpful, so regular exercise, such as to improve flexibility and strengthening, can help with balance. And as one may lose their balance and can cause a fall, it can do a lot of harm, such as for the elderly. So fall education and prevention interventions may be provided by the OT. Environmental evaluations and modifications, such as in the home, should also be conducted if falls are an area of concern. The OT can also address environmental barriers in the natural environment. OTs can recommend DME, such as shower chairs, grab bars, commodes, or even having a chair for long walking stretches such as in the hallway. Lighting can be adjusted, such as with dimmable lights to be more comfortable instead of ones that just go on and off, like super bright to dark. Environmental controls or assistive technology can also be used to control lights, such as with smart home technologies, like ones that you can use your voice on your phone or whatever. Another good idea is to practice in different lighting conditions with patients, such as bright sunlight to very dimly lit to near darkness, which should be the most challenging, like the near darkness, as this depends the most on one's vestibular system. Fall alert systems such as life alert are also good ideas for the geriatric population with these conditions. In terms of occupations, the OT can practice various activities that involve changes in one's position posturally or head movements, from walking to transfers to reading signs while simultaneously walking or pushing a wheelchair, for example. And it may be normal for symptoms to come on during rehab and participation in activities. And as such, people should carry medications with them, especially when going out should an attack occur, especially out in public. Staying hydrated helps counter the low salt levels, and it may be a good idea to bring some snacks even. Dressing and having the appropriate accessories when going out may be helpful, such as having sunglasses, earplugs, hats, anti-nausea bands or treatments such as ginger, peppermint, or even sparkling water for nausea and vomiting. As reading can be a trigger, other methods such as audiobooks are an option. And while shopping, one can go during a less busy time and be able to visually focus on one item at a time to give their eyes a break. Speaking of eyes, it is a good idea to educate and remind patients to have an up-to-date eye or contact lens prescription. People can avoid driving when there is significant glare, or such as during sunset or even at night, which when there is little light to provide visual cues for the environment, and one will be relying more on their vestibular system. Some nighttime glasses, such as those that have yellow tint, may help with reducing the glare from oncoming headlights. Freeways can be especially disorienting as the speed is so fast and there's fast-moving objects that zip by in the peripheral vision. And even like driving on long spans of bridges can be especially difficult. Try to focus on the horizon to help. As a passenger, you should avoid reading and other activities to avoid having a triggered attack. If possible, sit on the lower level on public transportation. Visually, complex patterns and movements can be uncomfortable. An example would be watching an action movie in the movie theater, because it's also a large screen that envelops your whole vision. Give the eyes rest breaks and practice deep breathing. When traveling in larger open places such as airports and train stations, one can be more easily disoriented due to overstimulation as well as the echoes from the walls. So the key is to avoid some environments or situations, but to also slowly introduce them and grade up activities with more movement as the patient becomes more comfortable with them. One can keep a journal to gain insight into potential triggers or use an app for it, and say how intense the activity demands were, how long the activity was, what the environment was like, what they ate around that time, and so on. Psychosocially, OTs can provide interventions to address panic attacks, anxiety, social isolation, and depression, as this can cause a vicious cycle. So interventions such as CBT, relaxation, slow and deep breathing, and stress management may help. And patients, if comfortable, should not keep their condition a secret from those who can provide a lot of support, such as family and friends who can lend a helping hand, such as during an onset of an attack, when out in public, or giving them reminders, or helping in any way that they can. Some tips for caregivers include avoiding giving advice, not minimizing their symptoms, and not taking things personally. Vestibular disorders can be a lonely journey as it is largely invisible to others, just like mental health disorders. But with education, a team approach, goal setting, lifestyle changes, rehabilitation, and a good support system and a discharge plan, OTs can help those with vestibular disorders lead healthy, meaningful lives. I hope this helps. If you found this video helpful, give it a thumbs up and share this video with your study groups. I'm Jeff, the OT Dude. Thanks for watching and good luck studying.